Thank you, Nadia, and thank you for the invitation. Good morning, everybody. So I'm going to talk about hereditary colorectal cancer syndromes, and actually, for the sake of time, since I only have 20 minutes, I will actually focus on Lynch syndrome. Interestingly enough, it was more than 100 years ago that this syndrome was clinically identified by the seamstress of Dr. Worthen, a pathologist. She was actually concerned because in her family there were several members who had passed away because of colorectal cancer, endometrial, or gastric cancer. And she approached Dr. Worthen concerned about her risk of developing any of these neoplasms. And unfortunately, she actually passed away at the age of 36 of metastatic endometrial cancer without him being able to do anything for that, but just beginning the story of what is now known as the Lynch syndrome. And what has changed since then? So definitely there's been a big revolution in technology and especially in genetic sequencing, and all this family history is now turning into different molecular phenotypes and findings that can help us identify these individuals who are at high risk of developing colorectal or other non-gastrointestinal cancers, and hopefully we can make this go back to their families in order to improve to decrease their incidence of cancer and improve their survival and quality of life. So let's focus on three main questions to me, which is why would we consider genetic testing in patients with cancer? First, because we want to estimate the cumulative risk, either at 5 years, 10 years, or lifetime risk of cancer in an individual and or her family. Because that identifying these individuals who are at sufficient risk may help to consider an enhanced screening or preventive strategies that will impact in their clinical management and decrease their incidence of cancer. And finally, because now we do have data that support that identification of some of these tumors with a specific germline defects might actually respond to a specific therapist. And we will go over this during the talk. So now we know that hereditary colorectal cancer is a very heterogeneous genetic entity. We would separate and differentiate based on the phenotype, two main types of hereditary colorectal cancer based on the presence of polyps, colon polyps, or the non-polyposis colorectal cancer syndromes. In the polyposis, we will have to separate based on the type of polyps, adenomas, hamartomas, or serrated polyps, and also the number of these, in case of adenomas, the number of adenomas, which might be hundreds or thousands of adenomas, and then we call it classical familial adenomatous polyposis, or between 20 and 100, in which case it's an attenuated FAP. The hamartomas polyposis syndromes are very easy to identify because they are phenotypically obvious, and we do have rare syndromes with specific genetic alterations, and these are the Poet-Sugar syndromes, the juvenile polyposis, and the Cowden syndrome. The serrated polyposis does not have a genetic underlying basis known yet. And then the non-polyposis syndromes that we differentiate based on the mismatch repair deficiency. If we identify this deficiency, then we call it the Lynch syndrome. In case we don't identify it in the germline testing, then we have the colorectal cancer type X or the MYH colorectal cancer. So what is the underlying genetic basis of these syndromes? We have for adenomatous polyposis, APC, MYH, and more recently, POL-E and POL-D1, and also NTHL1. For the hamartoma syndromes, we have STK11, SMAD4, BMPR1, and then P10. There's no genetic basis identified here. All the mismatch repair genes that encode for the Lynch syndrome. And again, MYH biallelic mutations explaining this kind of syndrome, which can also be identified here. So there is some cross phenotype. And then for these tumors, mutations in POL-E and POL-D1 have also been identified recently. So if we focus on one of these syndromes, let's imagine we are in the clinics and we are approached by a 43-year-old patient with a stage 2 right-sided colorectal cancer. Her pathology report described that her tumor had MSI and a loss of MLH1 protein expression. And a tumor genetic profiling analysis also revealed a hypermutated phenotype with more than 1,000 somatic mutations. So the patient is also reporting a family history of endometrial cancer in her mother, and she's seeking advice to find out if her children must undergo surveillance with colonoscopy. So my questions to the audience are if this is suspicious of a hereditary cancer syndrome. If so, what other molecular or genetic testings would you recommend to her? And finally, what type of surveillance would you recommend in her and also her close family members? So let's go through this and do some review of the literature. In terms of MSI and loss of expression of MLH1, we do have data that this is present in about 10 to 15% of all sporadic colorectal cancer, and that the main reason of this loss of expression of MLH1 is somatic tumor MLH1 promoter hypermethylation. And actually, there is data that supports that this promoter methylation is also correlated with tumor BRAF mutation. In this large series, we can see that among individuals who were germline mutation carriers and had mismatch repair deficiency and loss of expression of MLH1, the probability of finding a mutation in the BRAF gene was very low, 1.4%. In contrast, among those who also had loss of expression, mismatch repair deficiency, but were not mutation carriers in the germline, the frequency of BRAF mutation was pretty high, of 63%, and also correlated with almost 50% of them having methylation in the MLH1C region. Therefore, there is a very nice correlation between sporadic colorectal cancer with MSI and loss of expression of MLH1 and mutations in the BRAF mutation gene. In terms of how should we also interpret the immunostaining expression of these proteins in a pathology report, we should remember that in case there's a germline mutation in the MSH2 gene, it is very likely that both MSH2 and MSH6 proteins will not be expressed. In case of a germline mutation only in MSH6, the loss of expression will be only in this protein. And for MLH1 and PMS2, since they are also working together in the same complex, MLH1 will translate into lack of expression of MLH1 and PMS2 proteins, and PMS2 germline mutation with lack of expression of a PMS2. So what is the current algorithm in order to identify hereditary non-polyposis colorectal cancer based on performing mismatch repair deficiency testing in all patients with colorectal cancer? If this is negative, if there is retained expression of these proteins and microsatellite stable tumor, it is very unlikely that the Lynch syndrome with a germline mutation will be an underlying cause. If there is loss of MLH1, then we should exclude and rule out if there's a somatic mutation in BRAF. If this is mutated, as we saw before, it is very likely that this tumor will be an sporadic MSI high colorectal cancer tumor, and therefore that will be non-hereditary. On the other hand, if BRAF is wild type, or if there is loss of MSH2, MSH6, or PMS2, then germline testing should be performed. And if this germline mutation is identified, then this patient do have Lynch syndrome. But if it's negative, then we classify this individual as a Lynch-like syndrome. And what do we actually mean with a Lynch-like syndrome? What is the cause of these individuals who do not have a germline mutation but do have MSI and loss of expression of some of these proteins? First, it might be that a mutation in one of these genes has not been identified, and I do think that now current strategies of genetic analysis have improved quite a lot and are helping to identify as most of them. But very recently, and through tumor genetic profiling, it has been observed that also somatic biallelic mutations in these mismatch repair genes can explain a high proportion of these individuals who have loss of expression of these proteins and microsatellite instability, and they do not have a germline mutation. In these three series recently published, both from the clinic and the population-based cohort, we can see that once these individuals were ruled out a germline mutation in any of these genes, then they were sequenced in their tumor for mismatch repair somatic mutations. And very interestingly, between 52% and 70% of these individuals were carrying biallelic somatic mutations in these genes. So how is this changing the current algorithm of this process to diagnose Lynch syndrome or other syndromes? So we said that if a germline testing was positive, we would classify these individuals as a Lynch syndrome. But if it is negative, we may have to think to perform somatic genetic analysis of these tumors in order to identify if at least 50% of them do carry these somatic mutations. Because if that's the case, then this is actually an sporadic colorectal cancer, and this individual and their family members should not undergo high-risk screening, and their management would actually be based on the family history. So in summary, the etiology of mismatch repair deficiency in colorectal cancer might either be somatic or hereditary. In terms of somatic, the presence of a BRAF mutation or the presence of an MLH1 promoter hypermethylation will guide us towards this diagnosis, and also the finding of somatic mutations in the DNA mismatch repair genes. In contrast, a germline mutation in a DNA mismatch repair gene will be telling us that this is a Lynch syndrome, and therefore there is an inherited predisposition to develop colorectal, endometrial cancer, ovarian cancer, gastric, and small bowel. So let's talk a little bit about this Lynch syndrome. Hereditary cancer syndrome is the most common hereditary colorectal cancer syndrome. The cause are mutations in these genes, and it is being transmitted with an autosomal dominant pattern. So there is a 50% risk of transmitting the mutated allele to the descendants. The clinical phenotype is usually associated with an early onset of diagnosis, but this is not always true, as we will see later on. And there is a high risk of developing colorectal and endometrial cancer mainly, but also stomach, ovary, urinary tract, and small bowel tumors. In terms of tumor phenotype, both tumor-infiltrating lymphocytes, such as Crohn-like, it's a very common phenotype of these tumors, also the mucinous features, and then, as we said before, the loss of expression and of these mismatch repair proteins and the microsatellite instability. Unfortunately, there is a very clear underdiagnosis of this syndrome. And the main cause is that we do not have a clinical suspicion that this syndrome might be below or beyond a colorectal cancer patient. It either might be because a lot of centers do not perform microsatellite instability or immunohistochemistry routinely, or it may also be because family history remains largely unrecognized. We do not collect family history properly, or also because penetrance is not complete, and therefore these patients may not have a very significant family history. Nevertheless, the impact of the Lynch syndrome diagnosis, I believe it's very relevant, and it does have some clinical utility. I know this is an unfair cross-comparison, but I would like to highlight your attention towards the benefits of undergoing preventive colonoscopies in individuals who are mutation carriers, and we can see that in terms of overall survival, these individuals do have a great benefit with decreasing mortality of 65%. And if we do this unfair comparison with a very good chemotherapy in the adjuvant setting of individuals with colorectal cancer, we do also see a benefit in survival with decreased mortality of 20%, but we are now talking in a magnitude of months. And even in the metastatic setting, when adding panitumumab to a 4-FOXP4 regimen in wild-type KRAS colorectal cancer tumors, there is also a benefit in survival, but again in months. So there's no doubt that for these 3-5% of colorectal cancer patients that we can provide them with colonoscopy, this will definitely impact their survival. In terms of cost effectiveness, it has also been shown that a strategy of MLH1 that immunohistochemistry with BRAF testing actually is a cost-effective strategy for diagnosing Lynch syndrome, and the higher number of relatives that are being tested in a family after identification of a mutation, it makes this strategy even more cost-effective. So let's finish with three different critical current clinical questions regarding Lynch syndrome, which is getting some idea of what is the cumulative current risk by age to first cancer, in which organs are these first cancers most likely to cure, and what are actually the outcomes of these cancers. A very recent publication of a prospective follow-up of almost 2,000 mutation carriers undergoing the current surveillance with colonoscopy or gynecological screening worldwide has recently been published. And we can see that there are differences in the risk of developing cancer based on the gene that is mutated. So for MLH1, starting at age 25, there's a cumulative risk at age 70 of almost 50% of developing colorectal cancer. For MSH2, also starting at age 25, this risk is up to 35%. But then for MSH6 and PMS2, we can see a later age of onset of these tumors, and with a lower cumulative risk of 20% for MSH6 and almost 10% for PMS2. In terms of endometrial cancer, the highest risk of developing this tumor is for MSH2 and MSH6 mutation carriers, and it is a little bit lower risk for MLH1 and PMS2 mutation carriers. Interestingly, these individuals were actually undergoing periodic colonoscopies, and the mean time for those who developed colorectal cancer, the mean time since the last colonoscopy was almost 3 years in these individuals, with a median of 27 months. If a yearly colonoscopy is being done, only 6% of colorectal cancer were diagnosed, and this increased to 31% if the colonoscopy had been done 2 years before. So it seems to be very important that we can recommend these individuals a yearly follow-up with colonoscopy. And then finally, and as we will see also later on, these tumors tend to have a very good overall survival. In terms of colorectal cancer, a 10-year survival of 90%, endometrial 98%, and also for ovarian cancer, 89%. In terms of prevention, there is very nice data of a randomized study, the CAP2, that provided a great benefit of aspirin after 2 years of 600 milligrams per day of aspirin, with a 60% risk reduction of colorectal cancer. And this decrease in cancer incidence was also observed for non-colorectal cancers, with a 65% reduction in other extracolonic tumors associated to the Lynch syndrome. So finally, let's revise a little bit of the evidence that has been published after the TCGA analysis in colon and rectal cancer. And let's pay attention to this fraction of tumors that do have a hypermutation phenotype, mostly associated with microsatellite instability, and also mutations, either somatic biallelic mutations in any of these mismatch repair genes, but also the poly gene. These hypermutated tumors do actually encode for non-self neoantigens, and it was hypothesized that these neoantigens could actually increase an immune response to these tumors. And this was the rationale to actually design this study, a phase 2 clinical trial, including individuals with colorectal cancer and deficient in the mismatch repair system, including also a cohort with proficient mismatch repair tumors, and finally non-colorectal cancers with mismatch repair deficiency. And these individuals who had progressed to several lines of prior standard chemotherapies were treated with an anti-PD-1 therapy with pembrolizumab, 10 milligrams per kilogram every 2 weeks. So recent data was updated and presented at ASCO almost a month ago, and very interestingly, in this group of mismatch repair deficient colorectal cancer tumors, almost a 60% overall response rate was detected versus 0% in mismatch repair proficient. And we can see in this waterfall plot the big difference in responses among mismatch repair deficient colorectal cancers versus mismatch repair proficient. And actually, this overall response rate also translated in a very interesting progression-free survival and overall survival. Mismatch repair deficient colorectal cancer have not reached this median progression-free survival yet, versus 2.3 months in the mismatch repair proficient tumors and 6 months in terms of overall survival in this group compared to this one. So we are actually facing a new opportunity of targeted therapy in these individuals. So in conclusion, and for my take-home messages from this talk for all of you, I would like to recall that mismatch repair deficiency might either be sporadic due to biallelic somatic mutations or MLH1 hypermethylation, or it might be hereditary, and in this term related with the Lynch syndrome. Mismatch repair deficiency provides a very predictive information for therapeutic decision making. We didn't talk about the early stage, but it has been demonstrated that is lack of efficacy of 5-FU regimens. And in the advanced setting, we have a promising option of therapeutic making with benefit of immune checkpoint blockade, as it has been recently been observed. I would recommend to rule out Lynch syndrome after identification of a mismatch repair deficiency in a patient with colorectal cancer, because cancer prevention is possible for these individuals in terms of their risk of developing second tumors and also for their family members. This strategy is also cost-effective. And finally, these individuals do have an overall very good prognosis, and this is important for them to know to make their plans. So thank you for your attention.